Everybody, we'll give everybody a couple seconds to join. Good morning, and thank you for joining us for Starty Medical's webinar presented by Dr. Henry Lee on data and quality improvement to address disparities in neonatal care and outcomes. I am Tammy Jansen, co-founder and CFO of Starty Medical. For those of you who don't know us, Starty Medical is a precision nutrition company providing digital solutions to support nutrition and feeding practices for preterm infants in the Nicu. We've been hosting a series of educational webinars, all focused on the growth and development of preterm infants and the importance of feeding, nutrition, and gut health. This is a look at our past webinars. You can view any of them on demand by visiting our website at astartymedical.com. This is a glimpse at our incredible lineup of upcoming speakers. You can also find the details for these upcoming webinars on our website. Please join us for our next webinar on June 9th for a presentation by Dr. Jane Harding, Dr. Jane Alsweiler, and Dr. Chris McKinley, all the way from Auckland, New Zealand, for an update on management of neonatal hypoglycemia. These leading experts will discuss the pathophysiology of neonatal hypoglycemia, which babies are at risk, long-term effects of hypoglycemia on neurodevelopment, treatment options, and prevention options for babies at risk. Watch for the invitation for this informative webinar in your inbox. I'm now pleased to introduce our esteemed presenter and expert in the field of neonatal care, Dr. Henry Lee. Dr. Lee is Associate Professor of Pediatrics Neonatology at Stanford University. He serves as Chief Medical Officer of the California Perinatal Quality Care Collaborative, an organization of 139 NICUs committed to improving the quality of care for California's mothers and most vulnerable infants. His research projects, which have been funded by the NIH and AHRQ, include perinatal epidemiology and health disparities and evaluation of implementation strategies for neonatal care, including for breast milk provision and delivery room management. He has served as co-chair of the Neonatal Resuscitation Program Steering Committee of the American Academy of Pediatrics and is a member of the American Pediatric Society and Society for Pediatric Research. We'll have time for Q&A at the end of Dr. Lee's presentation. Please post your questions at any time throughout the presentation in the chat box on the right side of your screen. I'll now turn it over to you, Dr. Lee. Oh, Dr. Lee, you're muted.
Can you hear me now?
Yes, we can hear you now.
Okay, sorry about that.
Okay, okay, great.
All right. Give me 1 second to share my slides. Yeah, thanks, Tammy, and thanks everyone for being here. I am, just really feeling, in some ways not quite adequate to address this very important topic, but in many ways I think is part of the process of learning how to think about disparities and how to address it. It just helps to even talk about it and also hopefully maybe even learn from you, either today in the discussion or after. But yeah, I think first of all, just to kind of give a little bit of my background in sort of what I do on a day-to-day basis. I think a lot of it is quality improvement within our network in California. And at CP2CC, our California Perinatal Quality Care Collaborative, has grown over the years. Started in 1997, and over the past 20 years, it's grown to include pretty much almost all the NICUs in California, which covers about 50,000 NICU admissions, about 5,000 very low birth weight infants a year, and 10,000 of those NICU admissions, which we might consider to be very, very ill patients requiring a lot of intensive care. And One of the main things we do in quality improvement is really data driven, and this shows just a snapshot of the type of tools that we can provide to NICUs in terms of giving quality reports to help drive improvement and see where the gaps are. And this is another example of a snapshot. For example, this hospital can see that their dot there is, toward the left in orange, is their breast milk, human milk nutrition rate at discharge, and see that they're not doing quite as well, and therefore motivate change. And the variation here shows that there's opportunities for improvement for some of these units. And another sort of a report a figure that can help in this sort of control chart figure to see what the trends are, and you can see at least that this unit has been improving over time, the orange line, but then still lagging behind the average in California, therefore hopefully giving some motivation to continue to work on this as they already have been doing. So in our California network, we've also really sort of tried to think and innovate in quality improvement methodologies. And one of the main things that we've done are IHI style driven collaborative, really teams working together, QI projects. And these are some examples of the clinical topics that we've addressed over the years. And many of them have produced really good results. And we've also learned through the process of doing these QI projects, so that we have seen improvements in some of these outcomes like survival without morbidity, especially outcomes like necrotizing enterocolitis and nosocomial infection, severe intraventricular hemorrhage. Those have all improved over the past decade. But one thing that is sort of masked by that overall improvement is that there have been and remain significant disparities for certain groups. For example, this figure shows the disparities for Hispanic families and compared to white families in terms of the VLBW infants. And these are the components of the baby monitor composite quality indicator. And you can see here that especially those that are on the left, which might be considered a little bit more process-driven quality metrics, like human milk and neonatal steroids, for example, that non-Hispanic white infants do considerably better than Hispanic infants. And similarly, there are large disparities for Black families, and here you can see there on the far left, the human milk at discharge is significantly worse in terms of rates compared to white infants, and other process measures like neonatal steroids and timely eye exam. You can see here on the right that there are some measures that Black infants do better than white infants, where the red is better than blue, but that has to be taken into context in that the preterm birth rate for Black families is 2 times or more higher than white families, and therefore in some ways we don't actually even want those to be the same, but rather it should be better in some ways because the population is going to be higher. And this is a statistic perhaps that you're familiar with and we've gotten used to, but certainly it should continue to make us pause and really question why it is the case that in this country that there are these large disparities in infant mortality. So you can see here that even as our infant mortality is relatively higher than most other developed countries, but within our country there are large disparities within our country in infant mortality, especially for Black, and Native American, Alaska Native Hawaiian, Pacific Islander race, ethnicity backgrounds. And this has been known for a while, and this is a study by David and Collins back in 1997, the figures from that study, which shows that for, in terms of birth weight, and recognizing that low birth weight is an indicator of health and birth outcomes, that African-born Black infants had birth weights that were similar to US-born white infants. However, those who were US-born Black infants had significantly lower birth weight than both other groups. However, this advantage, so to speak, of the African-born Black infants would disappear just after one generation of being in the United States. And I think that speaks to ultimately the environment, the context here of the society contributing to this health outcome. These are some quotes from Dr. Sahira Long's paper in Breastfeeding Medicine, and I'll just read this quote from W.B. Du Bois. The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race. There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference, and that was in 1896. And so I think it continues perhaps to be an issue even more than 100 years later. This concept of race being a social construct has been talked about a lot, including by Dr. Cameron Jones. But ultimately, yes, race is a social construct with no biological or genetic basis, so that any disparities we have identified are at least in part or even largely, I think, socially mediated. And therefore, the solutions for such disparities will ultimately also need to be socially mediated. So if we think about infant mortality and trying to think about how can we, I guess, improve this in terms of the disparities that we see, we can sort of try to drill down further. And this figure shows the infant, neonatal, and post-neonatal mortality. So neonatal being 28 days or less, and that's shown in the darker color in the bottom parts of these bars. And so you can see that for infant mortality, the large component of it is going to be in the neonatal period. And ultimately, though, the disparities exist across races. You can see that the white is the first bar on the left, and Black infants are the second. But the disparity exists both in the neonatal and post-neonatal period, but certainly the neonatal period is the larger component. And we look at the causes of infant mortality. We can recognize that, as those of us who work in the Nicu, that probably the largest component of that mortality, as well as the disparity, is due to preterm birth. And so the Black-white infant mortality ratio, as well as all of these other conditions that are the main contributors to infant mortality, the different ratios of the Black-white difference in death rates. And so low birth weight, proxy for preterm birth, is very, very significant. But also notable are maternal complications. And then more postnatal mortality are accidents and sudden infant death or sudden unexpected infant death. So these are potentially, if we're going to try to impact this disparity in infant mortality, potential targets for where we might want to focus. And this is, I really appreciated these quotes from Isabel Wilkerson in her book Caste, and I'll just read it. It's with our current ruptures, it is not enough to not be racist or sexist. Our times call for being pro-African American, pro-women, pro-Latino, pro-Asian, pro-Indigenous, pro-humanity in all its manifestations. And we are responsible for our own ignorance, or with time and open-hearted enlightenment, our own wisdom. We are responsible for ourselves and our own deeds or misdeeds in our time and in our own space, and will be judged accordingly by succeeding generations. And I think from quality improvement framework, really from my perspective, as I've learned to sort of participate in quality improvement, we're in a mindset, I think, of continuous learning. And that I think that's what we really need to do in order to tackle these issues of disparity, to think about systems, to work together in teams, not just within our units, but really across different sectors and in public health, really finding the root causes to use data-driven methods. And then if there are missteps or things don't work out quite as we expected, just as in quality improvement, to not be discouraged, but look for those as opportunities to try something else or try harder. And so I'll try to think about that now for the remainder of our time, like how can we think about quality improvement and how it could apply to improving, reducing our disparities that we see in neonatal and infant health. And so these are some ways I think that we can consider this. And first of all, I think just as I noted, the biggest impact for infant mortality is going to be perhaps outside the NICU, the preterm birth rate, as well as some of the environmental factors. So how can we think about social problems that impact both maternal and neonatal health? Because if we think about how we're going to try to improve neonatal disparities, it's really unavoidable to not talk about maternal health, because the preterm birth rate as well as the environmental factors are going to be such a huge component. And then how can we improve the quality of how we address social factors in the NICU, once the baby is in our care? And then ultimately, with all of the quality improvement we do for, say, any clinical condition, how can we make sure that we are trying to keep in mind that we also have a goal of reducing disparities? So, this is a figure of infant mortality rates by state, and we can see that there are large disparities, differences across states in the U.S. And, when we think about these different causes, again, shown here, just short gestation, low birth weight, malformations, maternal complications, and going down this list, again, you can see some of these are things that we can care for, try to improve in the unit. A lot of them are going to be outside the unit. And this figure on the left is a figure of maternal pregnancy-related mortality by state. And what you can see there is that the darker shaded circles, which are more predominant in the top part of the figure, the higher rates of death, mortality for pregnant women, are particularly high for states that have a higher percent of Black families. And so when we think about, why do we see some of these disparities by state, by race, ethnicity, we can consider that there are sort of a multiple factors, multiple layers of what might cause these disparities, the root causes, so to speak. There's a historical context of intergenerational trauma. There are societal norms of racism and discrimination that persist. Neighborhood factors play a role, and healthcare system inequities to access. And then ultimately, there are disparities in the type of clinical care, the quality of care that families receive. And I'll try to point out some examples of these, really in many ways very briefly, because I would just like to try to give some examples and also consider that maybe you could have some examples that you could think of as well. This conceptual model for community determinants of maternal mortality I thought was very insightful, just showing that a patient doesn't enter into our hospital sort of in an equal sort of fashion. Two different individuals who come into our hospital with the same condition, whatever it might be, preeclampsia or preterm labor, have all of this in the background of who they are and their health sort of status that's going to impact the type of care that we're able to provide. That receiving the same from us in the hospital may not, if the social historical context of a person's health has been already influenced so much by their life course. So, a good example, I think, of a quality improvement framework that I've learned from is this group in Cincinnati, Cradle Cincinnati, and they have tackled this very, ambitious task of reducing infant mortality in their county. And just as kind of, briefly sort of considered, they've used a quality improvement framework and looked at what are the root causes, went into the community to engage with families to figure out, what can we do about this problem. And so, they're, I think, continuing to learn and do some great work, but this is a figure which shows that they have been making some impact already. And, it's this type of work takes years, I think, and it's a long-term commitment. But you can see here that although there remains a disparity in Black-white preterm birth rate related deaths, that they have made some really great progress in reducing that disparity thus far. And reducing preterm birth rate, I think, is a goal that many of us have had that still remains largely elusive. But I think this group showing that really addressing community factors being such an important part of it is really a key insight. And so this is just one page of really a very comprehensive and thoughtful, longer document. But you can see here, this is one of the examples of their approach that they have taken. Finding, just as we do in quality improvement for clinical outcomes, the key drivers to how they may be able to address some of these issues. And they're very community focused. So, for example, this first box up in the middle, first trimester access to prenatal care, which makes sense in terms of trying to address at least partially the preterm birth rate. And you can see all of the different ways that they have sought to improve this aspect of maternal pregnancy care. So yeah, when we think about the root causes in terms of the societal impact of infant mortality, it's for me, I think it was a little bit hard to know where to start. And I feel like I've just learned a lot from just reading, even within this past year, some of the really interesting and important work that others have done. And this figure from Wanda Barfield showing how social disadvantage can impact maternal and newborn health is sort of a framework where we can look at the different categories of factors that may impact maternal and neonatal health: community, family, the mother, and the fetus. So, there's been some work out in New York City that has really sort of highlighted the disparities to access that contributes to these disparities. And so in New York City, Black patients have a 8 times higher pregnancy-related mortality than white patients. And so you can recognize that there's not a biological basis for that. Ultimately, many factors probably, but probably access to care being a very key issue. And similarly for neonatal morbidity and mortality, this Dr. Elizabeth Howell and colleagues showed that 40% of the Black-white disparity and 30% of the Hispanic-white disparity could be explained by the hospital of birth. And so I think, certain patients are better cared for at certain hospitals. And I think having access that is more readily available is a key component of that. And so, the U.S. I think is somewhat lagging in other in terms of behind other countries in being able to provide access equitably to the population. And you can see it has improved somewhat since 2014 in the ACA, but there's still a lot of work to do. And particularly for women and low-income women who continue to have difficulty in having insurance and adequate coverage. And so these are some of the groups in particular that have less health insurance coverage: Black, Hispanic, Native American, Alaska Native, and Native Hawaiian Pacific Islanders, as well as non-citizens, are groups that are particularly vulnerable. And so I think we can continue to try to see how we can influence the policies that affect these. And I think Dr. Barfield notes in her commentary that politics is one aspect of how we can sort of impact infant mortality, and sometimes we think, oh, we're not necessarily political, but I think that I mean that word in a not a negative sense, but just in the way of like as a democracy, we can talk to our legislators as people who are healthcare professionals and what we feel might be helpful to contribute to health outcomes, on a population level. So similarly, this issue of structural racism and segregation of neighborhoods, I think, is shown here and how that impacts neonatal health. And I think you might consider that might drive poor health outcomes in general. But these investigators showed that for severe maternal morbidity, that one of the strongest factors for severe maternal morbidity was environmental, that the number of violent crimes or just any crime in a neighborhood increased risk, but particularly violent crimes at a rate that was really as high or actually significantly higher than what we might consider to be traditional clinical risk factors. And this was a study by Yang, Collins, and Burris in Journal of Perinatology recently that showed that that police killings of unarmed Black people, the state rates of that statistic was the higher that rate was associated with the higher Black preterm birth rate. So I think again, it's not a direct link, but I think highlights that the environmental context, the neighborhoods, and just the structures that are in place impact health and including for mothers and newborns. And similarly, this is again showing the neighborhood levels of environmental factors, and so this goes back to severe maternal morbidity, and showing that those neighborhoods that have a higher Black populations, ultimately and violent crimes is going to impact health just as much as any clinical risk factor that we might think of. Some other studies showing how the environment can play a factor. Spontaneous preterm birth has been shown to be associated with neighborhoods that have higher tap water nitrite concentrations, and at levels that are slightly elevated, but not necessarily considered dangerous by federal standards, which shows then that those standards are not quite enough. And typically also the nitrites are found in communities where there are synthetic fertilizers. So probably the farm worker community is going to be particularly affected. And there's numerous studies. There was a systematic review recently showing that pollution, heat exposure, and are related to preterm birth, low birth weight, and stillbirth. And the subpopulations at highest risk were persons with asthma as well as Black mothers. And so I think these are just some ways that, ultimately it might seem a little overwhelming. Some of these issues are not directly under our control, and yet they play a very important role in health outcomes for infants. And so I think as much as we're able to, we can try to affect change. Eviction during pregnancy has been associated with lower birth weight, gestational age, especially during second and third trimester. And then we recently found that incarceration during pregnancy also associated with increased preterm birth, low birth weight, mortality, and Nicu admissions. And I think, this in the context of many women of color being in prison for somewhat, for petty crimes or things like drug possession, and disproportionately affected, that also affects, their health, but their baby's health as well. In this past year with COVID pandemic, we have advocated for our families to be able to visit, even aside from other hospital regulations, there are benefits to parents being in the NICU, holding their baby and doing skin to skin and so forth, breast milk outcomes, and even maternal mental health. But we also know that prior to the pandemic, and especially during the pandemic, those who are socioeconomically disadvantaged and non-white Black families, those on public insurance, were significantly less likely to visit their babies due to a variety of factors, financial pressures, and job situation, and so forth. And it's worth noting that the U.S. is one of is 41 countries, including the developed countries, the only one that does not have universal parental leave. Although the current administration is working on legislation to try to implement that. So far, the work at the University of Texas, this Prenatal 3 Policy Impact Center, shows that that we have a lot of work to do in family leave policies. And the 5 green squares, those are the states that have sort of what might be considered reasonably good policies in terms of paid family leave and other sort of family-friendly practices. But most other states have a lot of work to do, and I think it's worth noting, perhaps wherever you might practice, to see how you might advocate for better policies for after childbirth for families. This work from Vermont Oxford showed that those states with policies that are more, friendly breastfeeding in the workplace, maternal leave, and other practices is associated with increased breast milk at discharge for VLBW infants. And studies have shown that the implementation of paid family leave in California was the first state to do this, resulted in basically increased ability for mothers to take time off, and was associated with the reduction in post-neonatal mortality during the same time in which it rose in other states. And similarly, there were the Family Leave Act, which was unpaid leave. The implementation of that was associated with decrease in preterm birth and infant mortality, but it was particularly impactful really just for college-educated and married mothers. So those who are less able to take advantage of these policies are also the ones most affected by disparities. So I think even if a federal legislation is passed, we still need to think about how appropriate people will have access, because that usually doesn't happen. This was a recent study showing sudden unexplained infant death, and as I noted before, that is one of the higher causes of postnatal mortality, of which there are disparities. And also noting that preterm infants are at increased risk for sudden unexplained infant death. And one of the main causes for this is an airway obstruction due to soft bedding. And so I think, again, there are disparities in education, as well as even in the NICU, how we might form families. And so I think, things like legislation to provide education, as well as to not allow soft bedding to be sold, actually, those could impact these disparities as well. So, yeah, Dr. James Collins gave this Silverman lecture at our recent PAS meeting, and I really appreciated his sort of concluding points to put structural racism on the agenda. If really what our goal is to impact disparities, name racism as a force, determining the distribution of other social determinants of health, and then ultimately, data routinely monitor for differential exposures, opportunities, and outcomes by race. And just to add to that, I think, as I've noted, women's health is just a key component. If we're working in infant mortality, we also have to, make sense to think about the mother's health in order to really affect change. And to do, as I've shown you, there's been really great research coming out linking these data sets of the environment, so that we can think about the social impacts of disparities, so that then ultimately we can act. And then I think we continue to learn and just partner with our colleagues in these various disciplines in order to really work together in this effort. And then, as those who are in healthcare professions, as well as in research and academic environments, I think we can't just look at the data and know that it exists, but really see what we can do to advocate for those who are in, whether it might be in government or in our healthcare fields, in the administrative positions, to try to think about where to allocate resources in order to impact these social factors. And then when we are providing care to our families, to be aware of the social context, environmental context from where they're from. And so kind of transitioning to that, like, how can we try, once we have a family and a baby in the NICU, to consider how we may improve quality in terms of addressing some of these social factors. And so I think I'm encouraged to hear and really sort of inspired by hearing about local NICUs that are creating health equity task forces. And what these task forces are doing are meeting to review data. I think both the quality data stratified by race, as well as some of the other, potential environmental factors that may be impacting care. These task forces can talk to families regarding what they think are gaps in care, advise the hospital administration, and then ultimately perform or advise on quality improvement activities. Also, I think it's important for us to continue to learn together, as well as provide resources for the next generation of healthcare professionals, and then providing education. And I'll speak to a little bit about that toward the end of the talk. I appreciate this document by from Oxford, showing how we can have potentially better practices for follow-through as I think a growing list. And this is just like really a very small portion of that long list, but I think these are really great potential action items that a task force or a group can work on. And so, for example, screening all families for social risks and social support using a standardized tool, using electronic health records to identify patterns and inform clinical decisions. So I'll talk about those examples a little bit. I really appreciate Dr. Meg Parker's work in this area, and she did some studies looking at what are some of the unmet needs that are infrequently assessed in terms of social factors when a family is in the NICU. And so, how much do we know about a family in terms of their housing, food, childcare, transportation, and so forth, their finances? Is it important for us to know? And I think it is, when we talk to them and we provide care for their baby and think about what's going to happen even after they go home, but also during their NICU stay. Also about how much do we know about the mental health of the parents. And so what this speaks to is that I think we need to have a standardized screening and referral process really for all of these issues, because it's going to impact how we're able to care for the baby together with the family as a team. Our group at Stanford, our task force did a review of the data and studied kangaroo care frequency for our families. And what they were able to find is that there's a disparity in kangaroo care for those who are having lower socioeconomic status and those who are limited English proficient, so not primarily English speaking, held their babies and did kangaroo care half as much as those who had more privilege. And so I think this shows that really, there's probably a lack of communication that's going on with these families. And speaking to limited English proficient, this study in Colorado showed that Spanish-speaking parents were 4 times more likely to incorrectly identify the diagnosis compared to English-speaking parents, and they had a lower understanding of NICU interventions. But even so, even though they had lower understanding, it may be because of the fact that physicians and nurses had less spoken encounters with these families. And even when they had those encounters, they provide updates in the native language less than half of the time. It's important, first of all, I think just it's kind of the right thing to do to communicate with families well, but also important for clinical outcomes. This study showed that parent comfort with English was associated with better outcomes ultimately. Less comfort was associated with more preventable adverse events. At CPQC, we're continuing to work on this, but one thing we have been able to do is come up with this tip sheet of trying to provide family-centered care for diverse families, and I think this is a work in progress. But one point is acculturation of the unit, particularly perhaps if you have families, whether it's language or some other factor where we're able to make a family feel comfortable, that they belong, that we welcome them. Particularly because the NICU can be such a traumatic and scary place for families who are seeing that for the first time. And so, for example, signs, multilingual signs can be helpful. Like I think, maybe if you've visited a foreign country, even though everything might be in a foreign language, it helps to see at least some words that are in English, just to feel like, oh, there must be somebody here who also speaks my language too, if I ask. And in a hospital, sometimes we have signs that are in multiple languages, but often they're the signs that are sort of discouraging some behavior, for example, like smoking or do not enter. But how much do we have other signs that are, really sort of welcoming and so forth in a language other than English, particularly if you're serving a population, a significant portion that speaks a different language. These are examples from colleagues at Santa Clara Valley Medical Center in San Jose, which I think are really great, showing various signs that are in multiple languages, and then also for a parent group that's being held in Spanish, sort of as equally important as a family group that's being held for parents who speak English. My surgical colleagues at Stanford did this project and its ongoing clinic. So you can see the headline there: Spanish-speaking families prefer native language when discussing surgical care. And that's probably an obvious sort of a statement. But what they were able to do was that their clinic, all staff members at the clinic, including the receptionist, triage, nurse practitioners, the surgeon, interact with patients and family in fluent Spanish. So they do not use an interpreter. To do something like that, I think it's really a great goal, particularly if you serve a significant population that speaks Spanish or other language, perhaps. That might be hard to do that like tomorrow, even if you decide that that's a good goal. But what can we do to sort of at least progress to something like that for our families than what we have now? As I've talked to colleagues, particularly in California, where we do care for many families who do speak a different language, primarily than English, that just having a phone interpreter or even a tablet interpreter available isn't sort of a sufficient sort of technology or tool. Ultimately, we need training. Our interpreters need training in providing family and patient-centered care. And then we also perhaps need training. How can we best use interpreters in these tools in order to provide empathetic and good care that allows for good communication, empowers our families to ask questions, and so forth. So, there's a lot of overlap in these categories that I've come up with, but ultimately, I think we can also think about how to apply this framework of thinking about disparities to quality improvement activities in our NICU. Because we know that these clinical outcomes, even within the NICU, there are disparities both within and across hospitals. This review by Nick Parker and Susan Huang was, I thought, really great recently in seminars that showed that, even as we apply quality improvement principles to our projects, that doesn't necessarily mean that disparity will be decreased. In fact, sometimes QI can increase disparities, or probably most of the time it maintains disparities. And really, we need to have a framework where we are actively trying to decrease disparities. And so, if we're thinking about how to do that better, we can target, not just the whole population, which we're going to do anyway, but really try to think about, are there specific aspects that can address the needs of these populations, have a culturally competent approach, and then have data collection that's going to be able to help us to do this, family-informed data, outcomes that are important to families, and then ultimately to not just focus on clinical factors, but address some of these social factors, non-clinical barriers that these minority populations might have. this was another great article on quality improvement with equity-focused quality improvement, to think about QI first with an equity lens, but really then moving to equity-focused QI, thinking about how do we reduce disparities. And so, these are some steps to promote a culture of equity, identify disparities, incorporate equity into design, involve families, community partners, consider alternative comparator groups, so think about stratifying by race or other socioeconomic factors, think about root causes and systems factors, data to inform these disparity trends, and then also after the fact approaching dissemination with an equity perspective. We've had these disparity or health equity dashboards in CPQCC by my colleague Yoko Profit, and it helps our units to see that even if they may be doing a certain having certain performance with a quality measure, to see are they doing as well by race, ethnicity. And so you can see here that this unit, that they do care for very diverse population, but ultimately it is the non-Hispanic white families that are having sort of the best outcomes in terms of survival without major morbidity. So you can question why that might be the case. And then this figure shows similarly that in this NICU, that non-Hispanic white families have a significantly higher human milk nutrition rate than Hispanic and Black families. And so, it's hard to know how to approach, like, what can we do about that? And we might think we could do the sort of the usual things, like let's try to get lactation support early and so forth, and educational materials. But by digging even further into the data, and this study from the Massachusetts Collaborative tracked in their breast milk nutrition project, showed that even though that these three groups, white, Black, Hispanic families, started with similar rates of breast milk providing mother's milk, day 7, day 14, even day 21, fairly equivalent. But starting with day 28, and then certainly after that, there became a very large drop-off for those who are caring for Black and Hispanic infants. And so I think that showed perhaps that there needs to be perhaps a target, perhaps there's something happening around day 21. What might that be? And I don't know, but that's where it's a start of saying, is it because these families are having to go back to work, or are they having transportation issues, or do they need a sort of a boost of education at that time, can sort of help to target these QI activities. So when we have a goal of improving breast milk provisions, a very common QI project, that we can't just focus on what we might consider to be a good toolkit, which is certainly the start and good basis, but we really have to consider all of these other factors if we're thinking about it from a disparity perspective, to consider what has occurred before these families can come to the hospital, what might be the current social factors either preventing visitation or pumping in their work environment, and then really being mindful about the data that we collect, talking to families to involve them from the beginning in these QI projects. So the electronic medical record system can support QI, as I've shown you, these, being able to see data in a way that drives disparity-focused QI is very important. So we can talk to our IT, EMR colleagues to help us to figure out how to do that, stratifying by various groups. And then ultimately also, some of our family-centered variables are not really being collected systematically. If I were to ask you how often do certain groups in your NICU do skin-to-skin holding or visit, I know that most of our EMRs are not really set up easily to do that right now. But if these are important measures, then we need to think about how can we take advantage of our EMR to help us to work on these issues. And then ultimately, I think we can all be learning and be better about how we can sort of use our learning to impact change in our community. So, implicit bias in healthcare workers has been described, and it's been shown to alter clinical practice. in many different clinical settings. So to learn about implicit bias, to test, to take tests and sort of talk about it. And what can we do about implicit bias? I think just being mindful of it is one step. But these there are seminars and sort of papers that can help us to think about what can we do when we recognize that there is implicit bias in order to try to help us to not let that affect or care of patients. And so this is a popular test. I think if you haven't taken, I would encourage you to take it to see sort of where you might stand. It's implicit bias, because most of the time we don't know that we actually have it, right? And and then check our messaging. Sometimes we when it's pointed out that we have some disparities, we might say we don't see color, or I treat patients the same. But really, that's not a completely negative thing, but we might not be quite actually doing what we can to advance health equity if we're sort of stuck there. And so, there are various training programs actually specific to the Nicu. These are some that are out there in order to maybe perhaps take as an individual or as a team together. And then, there's many books, I think, but this is one that comes to mind that can help us to sort of have this framework to not just think about not seeing color, but really thinking about how can I be proactive in advancing health equity. Twitter, I think, is a great platform where I've learned a lot by others who have pointed out various studies, and this is one platform, Evidence Neo, one group that's doing a lot of great work in this area. In California, we've had, and I know other states as well have had similar educational sessions, and we really had a great one in March on advancing anti-racism, some great speakers. And if you're interested, we still have a lot of materials from that workshop that's available on the CBQC website, and a variety of exercises that you can do either individually or perhaps as a team in order to continue to think about and learn about these issues. Because ultimately, it's probably not quite enough to say I treat patients and families equally, because we already know that there are disparities and families are not equal, and we need to think about how do we treat our patients and families equitably. So to end, this summary of sort of some of my thoughts, we can improve our data collection of non-clinical factors that may have impact on maternal and neonatal health. We can sort of work as individuals and as groups at a societal level to address racism and contributors to disparity, act at the NICU healthcare system level to address non-clinical contributors to disparity, improve our data systems in the hospital to address disparity, and improve quality improvement to advance health equity, perhaps having a health equity task force in your unit, and then perform quality improvement when we do work on clinical outcomes with the health equity lens and then health equity driven QI. I'll end with this quote from Isabel Wilkerson again from Cass. We are not personally responsible for what people who look like us did centuries ago, but we are responsible for what good or ill we do to people alive with us today. We are each of us responsible for every decision we make that hurts or harms another human being. All right, so thank you, and open to your thoughts and questions.
Great. Thank you so much, Dr. Lee. If anybody has any questions, please post them in the chat box on the right of your screen. And I have a couple here. How do you suggest forming a health equity group at our local NICU?
Yeah, and so I think for, just an example that comes to mind is our unit, in full disclosure, I'm not an active member of our health equity group at our local unit, but it was just a group of people. It's a group of people I think were interested in working in this, and just probably as any QI team, it's multidisciplinary, and I think particularly for this issue, that's so important. So physicians, nurses, but also social worker, of course, as well as interpreter, representative, but then ultimately, I think perhaps so important is a family representative to speak to some of these issues as well. So I think, yeah, having that sort of from the beginning, this notion that it really we're sort of learning together, particularly from the family, but from every member of the team. And I think just coming together and thinking about the gaps that might exist, looking at data, just as any QI team might do, to look at the data to see where are the gaps, and then to talk to families and to see where they think the gaps are. So yeah, I think just using the energy of people who are interested in this area, getting the buy-in of a variety of team members. And yeah, just as I noted, I think it was really great that our team was able to recognize this gap, and in some ways, to publish a paper saying, our unit provides half as much skin-to-skin care to our limited English proficient families. Like, who would want to admit that? But I think being able to show that and saying, hey, we're going to do something about it, I think it's really a great step.
Great. Some social factors that impact maternal and neonatal health are outside the scope of the healthcare team. How can we make progress to have influence in these areas?
Yeah, that's a great question. And, I'm still learning really about how to do that, and I'd like to learn more. But I think we do have to just think about how can we do that, and not just stop and say, okay, this is an important thing, and it makes sense, but sort of out of the scope of my day-to-day work. And although that might be partially true, I think I've seen examples of colleagues who are able to use that data and then go to, for example, a state, senator or state representative and say, hey, like, I work in the Nicu, and I think you care about this issue of, infant health, but did you know that this social factor is really like one of the biggest components of what might be impacting health? And I think Ohio is a great example where they've been able to do that, where healthcare systems have been able to work with legislators to get funding to say that, hey, if you want us to improve health outcomes, we need to really start at the community level, social factors. So I think the few times that I've actually spoken to legislators, their offices are pretty open to people coming to talk to them, and I think we don't necessarily recognize that as much as we could. So that's one thing that comes to mind. And then not just that, but ultimately is just there are probably groups that are working in the community that we're not aware of, that are invested in some of these social issues, but don't necessarily know that they have an impact on something like neonatal health. And so to just learn about those organizations, meet with them, and maybe something won't happen right away, but building those connections could perhaps lead to something down the line where there could be a partnership and working together to advance sort of multiple agendas, but ultimately, our agenda to improve neonatal health.
What are some key areas for research in reducing disparities?
Yeah, so research, I think I appreciate really all the research that I've been able to read, especially, some of the ones that I pointed out. And I think, one thing that comes to mind is linking data. We're sort of theoretically in a big data sort of era right now. But, some of those studies, like linking environmental factors to birth outcomes, are really neat, I think. And we probably haven't really sort of expanded our scope of thought to think about all the different environmental, social factors that could be related and potentially be important for infant health. So yeah, I think the ability to link data, large data sources is really important. And then, yeah, and I think ultimately we know a lot already. So I think now, just as they have that example in Cincinnati, we just need to do something about it and then see what happens, and really invest in something long-term, because some of, changing and impacting social factors and its impact on health, that takes, that's not gonna show an effect in a month or two, right? It takes a long time. And so to invest in sort of quality improvement implementation activities that are going to be long-term, that we think are right, and even if it doesn't show immediate impact, to really kind of stick with it, to continue to learn. And yeah, so now that we have this data, to actually do what we might consider quality improvement in order to impact change in these social factors.
And we have one more question. How do we engage everyone in the NICU team to be sensitive for this topic or have better buy-in to address during NICU stay?
Yeah, no, and I think that's not an easy question, but I think part of it is having some people, those people in the unit who are invested and motivated and interested to create something like a task force and strategize together and really to listen to our colleagues, to get a sense of what would help you. I think if something is forced on you as a healthcare worker, for me, I know like if some training is forced on me that I'm not exactly sure what it's about, then I might do it, but I don't necessarily take it to heart. And so I think really listening, having a two-way communication, seeing what the gaps are, and then doing it in a way that is hopefully challenging, but also encouraging, and sort of with the mentality of we're sort of doing this together. And this is a sort of different example, but a clinical example is delayed cord clamping. I think when I've seen QI to improve delayed cord clamping, if we tell our obstetric colleagues, for example, hey, we're going to start doing delayed cord clamping, so please do that. I think that doesn't always work out well if you don't also explain why, or of course, to of course tell them, hey, of course you care about our very preterm birth outcomes, and these are the evidence to show why it's important. And then you get a much better buy-in, I think, of involving them together in the process and sort of providing that sort of education, and being able to also listen to them to see what they think in order how to incorporate these practices. So similarly, yeah, I think having that two-way communication with our colleagues when we are thinking about these issues is very key.
Great. Well, Dr. Lee, I want to thank you so much for your time and your insights on this very important topic. I hope everybody comes back to see us for our next webinar on June 9th. Thanks so much. Take care.
Thank you, Dan. Thank you, everyone. Appreciate it.